Hello everyone. Today we will be discussing regarding seizures, convulsions, management of febrile and neonatal seizures. So before moving to the topic, we should have a clear idea regarding what constitutes a seizure, what constitutes a convulsion, and then a clear distinction between epilepsy and these two clinical entities. So coming to seizure first. So seizure is any sudden any sudden disruption of brain resulting in neuronal firing. Okay, so that neuronal firing can be neuronal firing. So this neuronal firing can be synchronous or excessive. Okay, and this will result in changes of movement. Okay, sensation, sometimes behavior also. Okay, so this is all about seizure. Then what is convulsion? So any involuntary movement resulting from seizure is called a convulsion. Then what is epilepsy? Epilepsy is greater than or is equal to two episodes of seizure that is coming without any provocation. So that is what we call it as epilepsy. Okay. So seizure is any sudden disruption of uh, brain activity that is caused by abnormal, excessive, or synchronous neuronal firing. Okay. So based on which there will be changes in the movement, sensation, or even awareness. Okay. So we have to have this definition in mind. Now coming to the learning objectives. So we should know what is a seizure, convulsion, and epilepsy, and the distinction between them. Recognize the types of seizure, then the differential diagnosis. Remember, seizure is not a medical condition; it is a clinical entity. Okay, so it is a clinical entity. It is not a medical diagnosis. So we have to as a physician, so we have to identify the actual cause of the seizure, then how to approach the investigation modalities from bedside to imaging modalities, and what are all the steps for managing febrile seizure in particular for a 1 year old and a neonatal seizure for a 10-year-old, followed by a first aid management and a hospital support system for something called status epilepticus. Okay, so status epilepticus is nothing but any seizure activity for greater than for 5 minutes is called the status epilepticus. So coming to definition, as I said, seizure is transient, abnormal, synchronous neuronal discharges. Okay, so convulsion, they are motor manifestations of some seizures resulting in jerks or stiffening. Epilepsy is greater than or equal to two unprovoked seizures. So coming to the neuronal discharge. So in the brain, the activities that we tend to do results from two things. One due to excitatory neurotransmitters, the other one due to inhibitory neurotransmitters. Okay. So this excitatory neurotransmitters predominantly is glutamate. The inhibitory is GABA receptors. Okay. So normally there will be a balance between these two neurotransmitters, that is GABA as well as glutamate. Okay, so because of this only we are able to produce movements. Okay, when there is an imbalance, that could be due to increase in glutamate receptors or due to decrease in GABA receptors. This could happen either way. Then the balance is out, which will then there will be an imbalance which will result in seizures. Okay, so coming to the main distinction, not all seizures are will end up with convulsion. Some can go as absent seizures, some can go as myoclonic seizures, some can go as atonic seizures. Okay, but all convulsions are definitely seizures. Okay, and then febrile seizures are something that is associated with fever. Okay, without fever, there is no possibility of febrile seizures, and it typically occurs in children between 6 months to 5 years of age with a strong male predominance, with a strong family history or family predisposition. Okay, so there will be no active CNS infection in case of febrile seizures. Okay, now coming to the different types of seizures, simple and complex seizures. Okay, in case of simple seizure, it is caused by generalized seizure, which duration of less than 15 minutes with a single episode in 24 hours, and there will be normal post-ictal phase. Whereas in case of complex seizure, there will be focal, and it will be greater than or equal to 15 minutes with more than two episodes within 24 hours, which requires further evaluation. In case of simple seizure, the entire brain with both hemisphere will be involved. Okay. Whereas right both hemisphere in the sense right and left hemisphere. Whereas in case of a focal seizure, only a specific part of the brain will be involved. So that is the main difference between generalized seizure and focal seizure. So what are the different manifestations? In case of focal seizure, there will be aura, automatism, and may then sometimes focal seizure may then proceed to generalized version. Okay. So general seizure is classified again into five types: so tonic seizure, clonic seizure, tonic clonic seizure, then absent seizure, myoclonic seizure, and atonic seizure. Okay. So what is the difference between these two? So usually it will start with the tonic seizure, then clonic seizure, which will have a post-ictal sleep. So what is this post-ictal space? So normally in some of the seizures, there will be a phase wherein the brain's neuronal firing will be stopped, but the person will take some time to recover, which we usually call it as a post-ictal phase. Okay, and sometimes associated with a tongue bite. So wherein the patient will be expressing an involuntary dance type movement, which will be out of control for this patient. So in case of absent seizures, there will be 5 to 15 seconds of staring. Then the eyelid will flutter more than a heroine, and there will be a 3 hertz spike wave in EEG, which I will be showing at the last. Then coming to myoclonic seizure, there will be lightning like jerks clustered usually in the morning. Then, in case of atonic seizure, the muscle will lose its tone. Okay, there will be sudden loss of tone, which will result in fall. Okay, wherein there will be a helmet that is often needed. Imagine a person sitting or standing in whatever posture they are. Suddenly, they will lose the entire muscle tone. The resting muscle tone will be lost, which will result in sudden fall. Okay, so these are all the types of seizure. So this absent seizure is generally misdiagnosed as ADHD, or people will be labeled as daydreamers. Okay, because people will tend to associate seizures with a sudden involuntary muscle movements or limb movements. Whereas in case of absent seizure, there will be a sudden loss of consciousness, or the person will simply stare at it. Okay, so this will result in, especially in case of children, they will lose their academic performance. Okay, which will result in academic performance will be lost. Okay, so which will further result in clinical depression, mild clinical depression, anxiety related disorders, and they will end up with suboptimal or lower performance in life. Okay, so coming to the pathophysiology, which we have already discussed, there will be an excitation and inhibition imbalance. Sometimes, most of the times, there will be glutamate greater than GABA, which will result in sudden excitation, wherein the neuronal firing will be constant. Okay, because of neuronal firing, different body movements or different types of sensation will be here heard. Okay, in case of infants, this network synchronicity, there is always a lower threshold. So, wherein in case of febrile seizures, this neuronal stability will be altered by the presence of cytokines like IL-1 beta and IL-6 in case of fever. Okay, and then sometimes in structural or metabolic lesions also there will be hyperexcitability, especially in space occupying lesions. Okay, or sometimes it can happen in also in case of a traumatic brain injury. Okay, if there is an external trauma also, you can expect such type of things. The common causes of convulsion in a 1-year-old include a simple febrile seizure, which is the most common, resulting from viral URI or otitis media or Roseella infantum or influenza. Then CNS infections like meningitis or encephalitis in cerebral malaria. Systemic infection with a high fever. Okay, so there will be a spike in the cytokines, which will alter the neuronal stability, especially in case of pneumonia, urinary tract infection, or sepsis. And the most important thing, especially in case of neonates, okay, there will be hypoglycemia, hyponatremia, and hypoelectrocalcemia. So there will be if there is an electrolyte imbalance, okay, there also you will find seizure activity because of sodium dependent and calcium dependent channels. Okay, it is a very rare cause. Okay, so in case of post immunization, especially in case of DPT and MMR, there could be febrile seizures. Sometimes epilepsy will present with coincidental epilepsy will present with febrile seizure, which is a differential diagnosis in this case. Okay. Now coming to the mnemonic, what are the causes of seizures? This is for adults. Okay. So vascular cause includes stroke, hemorrhage, or venous thrombosis. Infectious cause include meningitis, encephalitis, or cerebral malaria. Then traumatic brain injury, organophosphorus poisoning, tricyclic antidepressants, tramadol, quinolones, autoimmune conditions. Then metabolic conditions, which we have discussed briefly, like hypoglycemia, natremia, calcemia, magnesemia, uremia, and hepatic illness. Then primary epilepsies, then drug-induced. Then in the case of neoplasm, cortical tumors as well as tuberous sclerosis and some type of gliomas also can cause seizures. In addition to that, in case of pregnancy, there will be eclampsia. So this can also cause seizure. Another important differential diagnosis is syncope, especially in case of atonic seizures. Okay, so both the cases, the patient will suddenly fall down. Okay, so this is syncope is an important differential diagnosis, whereas the other things are causes for which a vitamin. Okay, is the mnemonic. V stands for vascular, I stands for infection, T stands for trauma, E stands for autoimmune, M stands for metabolic, I again stands for idiopathic or iatrogenic, and N stands for neoplasm. So this is for pediatrics, neonatal stroke or intraventricular hemorrhage. Then again, infection same cause, whereas birth trauma can cause, sometimes accidental injection can also cause. And then post-infectious encephalitis in old age. Similarly, in metabolic, pyroxene dependent can also cause in addition to the existing causes. Then genetic epilepsies in case of SNA1 gene mutation and medication effects and low-grade gliomas. Okay. So febrile seizures, as we have already discussed, are very common in 6 months to 5 years of age. Peak incidence in 12 to 18 months, where there is a strong male predominance, mostly associated with viral illness. Excellent prognosis in case of febrile seizures, where it ceases to exist beyond 5 years of age. Now coming to febrile seizures, a differential diagnosis includes a reverse syncope, breath-holding spells, and shuddering spells. The most important red flag include if the seizure occur below 12 months of age and if there is any signs of focal seizures and there is a prolonged post-ictal phase associated with the meningeal signs and there is a toxic look. Okay, you have to consider for CNS infection, metabolic derangement and first epilepsy presentation also. So coming to the management, you have to secure this airway breathing circulation just like in case of any other emergency, lateral position, suction and oxygen if needed. You can start with a diazepam 0.3 mg per kg or 0.5 mg per kg if it is through rectal absorption. Then midazolam is also safe drug. So initially we have to stop the seizures with benzodiazepines. Okay, so benzodiazepines. Then if it is persistent, you can go for lorazepam 0.1 mg per kg or phenytoin. Usually this is done in the hospital setup. But this can be done in even in case of home setup if there is a persistent or known case of febrile seizure. And fever control is a important thing wherein paracetamol, tepid sponging, and hundreds of extra layers has to be done. So coming to the investigations, CBC, then glucose, electrolytes, cultures, and lumbar puncture in case of meningitis suspicion is there. Imaging is the first main imaging that has to be done. Then, as far as CT and MRI is concerned, there is very minimal role because the underlying reason is a neuronal firing, which is present at the molecular level, okay, which cannot be suspected at the CTR, which cannot be found out during using CT or MRI. So, this can be done only if you suspect any space occupying lesion as the differential diagnosis or any trauma. Okay, only in these cases, CT and MRI are useful. And if it is less than 1 year, admission is suggested. And any complex seizures features or suspected CNS infection is also there. Admission is warranted in case of febrile seizures. Parental reassurance is the most important thing when it is benign and no brain damage is suspected. Recurrence is also quite common, wherein in another episode of fever, there will be a 30 to 40% chance if there is a family history and if the first presentation is less than 1 year. Intermittent diazepam during febrile illness in selected cases can be suggested, but anti-epileptic drug prophylaxis is rarely indicated and it is the domain of pediatrician or a neurologist to decide upon. Okay. or a neurologist necessary. Okay. So what if instead of an infant, it is a neonate? Okay. In case of neonate, you can't expect a tonic-clonic seizure or myoclonic seizure because the baby will always be sleeping, only will be waking up for drinking milk. Okay. So in this case, you have to suspect if there is an ocular deviation, constant chewing and bicycling, and apnea or staring. Okay. So, though clonic, tonic, and myoclonic can occur, apnea is the single most sign. Always search for underlying etiology like metabolic infection or intravesicular hemorrhage. The immediate management includes the stabilize the airway breathing circulation, check for glucose, and if there is a hypoglycemia, 10% dextrose 2 ml per kg IV bolus infusion. And first line management, if there is an epilepsy is suspected with phenobarbital 20 mg per kg IV. If persistent, go for phenytoin or phosphenityne, then midazolam infusion 0.1 to 0.3 mg per kg if it is a refractive case. Okay. So hypocalcemia again has to be corrected based on ECG monitoring, hypomagnesemia, and if there is any infection, go for broad spectrum antibiotics and then adjust later based on the culture. Vitamin B6 deficiency is also quite a common reason for neonatal seizures. So, coming to the investigations, imaging only if there are any red flag signs, or else go for EEG alone. Then special tests in case of neonates include ammonia, lactate, plasma amino acid, urine organic acid, genetic or autoimmune panels. Okay, so this is the 3 hertz spike that you tend to see in absent seizures. Okay, that we discussed in the beginning. Then are non-epileptic events like syncope, other things. Okay. So coming to status epilepticus, which is again an emergency, if the seizure is more than 5 minutes and there is without any recovery, start with benzodiazepine. Second line include phenytoin, valproate, levocetirizine, levetiracetam, and then refractory suggested for continuous EEG monitoring with midazolam or propofol infusion. Parallelly, you have to check for glucose, electrolyte, thiamine, pyridoxine in case of malnourishment, and also toxicology screening is also suggested. So to sum it up, in case of febrile seizure, ABC is the and you have to check for airway breathing circulation, give benzodiazepine, control the fever. Lab investigations only if indicated, then discharge with proper counseling. But if it is a neonate, most of the time just check in for hypoglycemia and give glucose bolus, and then go for phenobarbital, etiology workup, targeted therapy in the NICU monitoring. Okay, so this is